Welcome to the Faster Podcast by FLO Cycling, the podcast where we talk about anything and everything that makes you faster on your bike. This is Season 1, Episode 3, and today we have Doctors Dane DeLozier and Mike Smith, the owners of Revo Physiotherapy and Sports Performance, joining us on the show. Revo PT blends physical therapy, personal training, and state-of-the-art biomechanics technology to treat and prevent injuries and improve sports performance. Listen to this episode to learn how to fine-tune your body and become a faster cyclist. All right, so Dane and Matt, welcome to the show. Thanks so much for coming on, guys. How you doing today?
Awesome. Thanks for having us.
Doing great, guys. Thanks a ton.
Very cool. Very cool. John and I are actually coming out to Denver next week. We're going to do some skiing in Vail and Beaver Creek. You guys are in Boulder, right?
Yep, that's right.
Beautiful
Sweet,
Boulder, man. You guys are going to hit it just right. Snow's coming in for you.
Yeah, I was going to say, do your snow dance for us because we don't have very good luck when it comes to snowing, even skiing. We always show up and the next week it snows. So, yeah, do your snow dance.
Oh, man.
All right. So as we just did a few podcasts already in this episode, in this series, and we've already talked about coaching. We've talked about virtual coaches. We've talked about real coaches. We've talked about training plans, how to develop them. We've talked about strength training plans, and we've really looked at everything that athletes can do to make themselves fitter and faster on a bike. And in a perfect world, of course, you just keep doing that and nothing ever goes wrong and you keep getting fitter and fitter. But in reality, unfortunately, injuries do happen and you can have traumatic injuries, you can have overuse injuries, and that is a part of cycling and sport. So we wanted to have you guys on the show today because you are both experts in injury prevention, and specifically with cycling in general. You guys work with some of the top cyclists in the sport. So I figure we have a lot to get into today, and we might as well just jump right into some of the questions. And we will start with just a general question on cycling and injury. And that would be, what percentage of cyclists actually deal with injury?
Guys, in all honesty, I'd say pending a certain level of activity or of participation, I say over 90%. We're dealing with the vast majority of cyclists at some point get injured doing something.
Wow. So
yeah.
There's two basic types of injury that we look at. One being traumatic, where, that would happen during a crash. And the second being non-traumatic. So something like an overuse injury or anything else in that area. So what are some of the most common non-traumatic cycling injuries that you guys see on when you're treating people on a daily basis?
Yeah, I think the most common injury we run into is just anterior knee pain, right? Not necessarily a traumatic thing, but more overuse. We see low back pain, hip pain as well.
Okay.
Those are the most common things we see.
And what are some of the most common causes for those non-traumatic injuries? Are we talking tightness, muscle imbalances, movement pattern issues? What do you see?
Yeah, that's a really great example. I would say most of it's movement pattern related, unless this person's having pain all the time, on the couch, at their desk, whatever it is, we could see an injury taking place there. But a lot of times it's a movement pattern that's overuse, right? Moving a little bit off, 50,000 times you get on the bike, you're doing the wrong thing. We see that quite a bit.
Yeah, right on. Another thing, when I first started getting into cycling, one thing I heard, it's not if you crash, but when you crash. And, a lot of times crashes can result in some road rash, I suppose, if you're lucky, but sometimes you get into some traumatic injuries. So what are some of the most common traumatic injuries you see when a cyclist comes in?
We see a lot of upper extremity injuries with cycling just because, unfortunately, it's usually one of the first things that hits the ground.
Yeah.
Or even more unfortunately, sometimes it's not the ground, it's a tree or a rock or something.
Yeah.
And then on the very kind of more severe end of it, we'll see people with like pelvic type fractures, high femoral fractures, who've either been hit by another object, God forbid, like a car, or have gone straight down onto their side, and literally the first thing to hit the asphalt is your bony hip sometimes. So you can really see a pretty wide range.
Right on.
Wow.
Yeah.
Okay, so when it comes to pain, there's this premise that no pain, no gain, and a lot of us as endurance athletes, I'm reading a psychology book on sport right now. We're actually going to interview a sports psychologist on the show, and one of the big topics is trying to differentiate between suffering pain, your VO2 max or your aerobic system is screaming at you, and pain as in I'm getting injured. So how as athletes do we know when we should stop? What is the type of pain or what type of symptoms should we look at? And what are indicators that we should stop and maybe come see a professional?
I think a lot of cyclists right now too, they fortunately have been through other sports where they know what kind of like workout pain is. We know what muscle burn is like, and that's the addicting part. That's why we kind of like it. Right? I think it's the nature of those two. Like mechanical, either muscle, tissue, tendon pain, just feels different than a super hard workout.
Okay.
It's one of those things where if it doesn't quite feel right, then honestly, guys, it's probably usually not.
Not right, yeah.
And for the stubborn people, this is probably a better follow-up question. For the stubborn people who say, I'll just stretch it or ice it and I'll just do this, but when do we know it's too far? Like when do we stop? Is an ache okay? Or what do we look at? Is it if it gets progressively worse? Is that bad? What is a marker?
Yeah, I think aches are fine. Soreness is perfectly fine. That's part of sport in general. When you're pushing yourself, you're going to feel that. Swelling is usually a sign that we need to be paying really close attention. Discoloration, bruising. If you're looking at the overall trend of what your knee feels like and it's getting worse and worse, you need to have somebody take a look at it.
Okay, awesome. So for all of us men who don't think that we need doctors, we actually might. So that's
I've also heard things like if the pain is sharp, that's also a very, clear indicator that something is off or wrong.
Yeah, usually if it's sharp, if it's mechanical in nature, meaning like it hurts when I do this, other than like a little bit of saddle rub or something like that, it's usually a good sign to see someone. Like when I turn my knee in like so, it's debilitating, then yeah, you got to see someone.
Yeah, okay.
And one thing we tell people a lot is unfortunately pain is it's a delayed indicator. A lot of times, like by the time you feel pain, something's been going wrong for a while already. So we try and get people in sooner than later. Absolutely.
Okay, cool. So if unfortunately, and when injury does occur, obviously not the traumatic type, we're looking at more at the overuse type. I guess both could apply, but what is our best plan of action when an injury happens?
As you said, severity can certainly help you decide. In a traumatic injury, I would highly suggest you seek out medical care from a physician. If you're right, like having concern of, have I fractured a bone? Go see your doctor.
Absolutely.
If you are having anterior knee pain, go see a physical therapist. Okay. They can help assess your movement, range of motion, all the things that we really pay attention.
Okay.
You can have that assessed.
Very, very good. Okay, so one of the big things that most of us fear with injury is that we're going to lose fitness. We spend months, if not years at times, building up to this level of fitness, and then all of a sudden we're injured, and the doctor says stop, or the PT says slow down. What is one of the best ways that we can minimize fitness loss while injured?
That's something we deal with quite a bit with some of our cyclists. A good way to do it, guys, is we find ways around it. So we can get cardiovascular response without specific, bike motion. One good thing about cycling is that it's mostly non-weight bearing. We can find ways to adjust your position, but then we use things like upper body, ski ergs. We use legless Aerodyne bikes to really kind of jumpstart the whole cardiovascular system and maintain that heart fitness. They found through a ton of research that your heart rate response to upper body work is actually much more severe than lower body. So you can maintain a ton of fitness just by jumping on an arm bike or a ski erg, or just by throwing your arms over your head.
Wow.
Very interesting.
Did you say that the upper body responds better to cardiovascular than the lower body?
It's more severe. So If I were to hit a speed bag, for 10 minutes, my heart rate would be jacked. But if I were to go for an easy jog for 10 minutes, it wouldn't really be that bad.
Okay.
So we respond kind of more severely from upper body endurance work than lower body.
Okay. Cool. Very cool.
And then if we are injured and we're getting obviously our cardio in some other way, a lot of things I've always heard that you can focus on technique or something like that when injured. Are there any other things that you guys would suggest if we are injured that we can work on that will help us return stronger when we do?
Sure. I mean, we look at overall movement patterns, right? As a cyclist, yes, I want to be on the bike as much as I possibly can, but sometimes that's not possible. We're looking at squat mechanics, basic techniques with even Olympic lifting. There's lots of ways we can say, for example, offload the front of the knee and get a lot of weight bearing strength done. And we'll see lots of translation over to the bike.
Nice. Okay. All right. I've been one of those guys who's been injured more times than I'd like to admit. And for me, it's always an overuse injury. I think I've had 15 or 20 MRIs in the last 10 years. And in that process, I've seen a lot of PTs. Some of them have been phenomenally good, and some of them have been, I hate to use this term, I don't know how else to say it, but like the old lady who just says, I know your type, you have to stop working out. So you get this range of PTs that are really, really good and then not so good. What are some things that our athletes, our listeners, maybe some questions they can ask their PT that will give them an idea that they're at the right office if they're not obviously at Revo PT?
Well, let's go back and talk about your 15 MRIs within 2 years. Good Lord, man.
Yeah, a few years. I got some questions that'll.
He's radioactive.
Yeah.
I was going to say, we need to consult other times. Good Lord.
Yeah, no, it's wild. I got a couple questions that we can talk about on that after the fact. But no, I'm an odd case. I've literally flown around the country. I've seen probably 15 to 20 PTs in the last, like I said, 5-10 years, and I've seen the best of the best. And it's I have this really weird injury pattern or history. But yeah, no, it's a bit of a long story. But yeah, so like I said, I've seen the list of good to bad, and what are some indicators that we know we're in good hands? Yeah,
no, great question. I think just showing up and just looking around you, that's a good place to start. Right? If you show up to an outpatient orthopedics office and you're a pretty high level athlete, you're working out 5-6 days a week, and all you see are people who are 80 years old and above around you, you might just want to raise an eyebrow as to how much experience do my practitioners have in treating someone with my goals. So it's good to ask your PT if they are involved with what you do, like what your guys' primary sport obviously being cycling. Usually you want to err towards someone who is at least familiar with the metabolic demands, with the physical demands, and who has at least, been somewhat of a cyclist themselves.
Yeah, and the movement patterns, if you're saying that's so key, I'm assuming, even if they're not familiar with how you sit or ride a bike, that also becomes pretty important.
Exactly. There's, especially with bikes, there's a ton of minutia that we can go into when it comes to contributing factors, which may be kind of creating your situation. So you want to have someone who's at least vaguely familiar. If you're a high-level Olympic lifter, you want to go to someone who maybe knows Olympic lifts. Or if you're a high-level swimmer, you want to go to someone who's dealt with a lot of swimmers before.
Very cool.
Yeah.
So let's assume that we've come to somebody like you, got an anterior knee pain issue. We've been coming to treatment for a while. What are some of the indicators that tell us when it's safe to return to training? How do we make our way back?
Sure. We don't really use this, binary, yes, you're ready to go, or no, you're not. So similar to a skier, right? When we return to snow, we don't go bell to bell until your knee's crushed. We do a couple runs in the same way we do on the bike. Let's go for 30-minute ride.
Yeah.
We use those little tests along the way. So it's actually pretty easy to decide. However, it's usually nice to have a third party helping you do that.
Yeah. Okay. And so I'm guessing, when we do start back, you're saying quick, short rides, we probably want to put ourselves in sort of a base phase of training. I mean, we're not going to be doing anything other than just getting ourselves back on the bike. Is that what you would recommend?
Yeah, exactly, guys. And one thing that we kind of hang our hats on too, more often than not, is we use kind of a criterion-based progression. So if you know someone who has kind of been through the deal before, people, inevitably the first question is, how long is this going to take? Right? Is this a 2-week? Is this a 4-week? And then we look at them straight in the eye and we'll say, like, well, how long or how much are you willing to invest in it? You know? So we have people kind of return to sport when they pass the appropriate tests as well.
Okay.
So, I mean, just to earn the right to get back on the bike, you have to show us that you can do that without, immediately jumping right back into the same bad pattern.
And do you, when you are having those tests, do you have tests, when you're looking at somebody saying, okay, now you've gone through these shorter 30-minute rides to get yourself familiar, do you have another test that says, hey, now we can start and put some higher intensity work in there. We can start, we want to put you out and test your FTP to see where you are after we've had this bit of a downturn. Do you have markers there as well?
Sure. We're not necessarily using physiological testing, but we use a motion capture system. We can look at your knee tracking on and off the bike. We also use surface EMG. So that measures the electrical signals that are going through the various muscles in your body. Most of the time, we're looking at glute, quad, and hamstring.
Yep.
We want to see a certain ratio of activation in a squat during the pedal stroke, and that gives us a guide as well.
What motion tracking system are you using, out of curiosity?
We partner with a company called Extremity out of Munich.
Yeah, Chris and I actually, when we were in university, or college, as you say it here in America, we always say university because we're Canadian, but we did a final project that was based on motion capture, and it was Vicon system, which was actually pretty interesting. So I've got some familiarity with that. It's pretty cool stuff.
Yeah, it's awesome.
Yep. All right, so let's go to, we'll lead into my oddity. I guess we can talk about injury potential a little bit. And you guys, when you talk about movement screens, are you using the FMS system?
So we use we've kind of created our own integrative movement screen. So like we have the luxury, guys, of seeing everyone, like we have this big physical therapy background, right? So we know a ton of research associated with different parts of movements and most importantly, like predictive movement patterns, essentially, that the correlation is high, for injury. So we start with the basic, table assessment, just like you would go into a PT. And if you had a normal injury, we have kind of our own little run through that we go through. So we look at joint range of motion, all the way from ankles up to cervical spine, right? Anything that you use in sport, which is everything. So we start on the table. We get up into we don't use an FMS. We use parts of the SFMA. Yep. And then that leads us into a whole bunch of movement capture, video capture, and EMG analysis. So we take people mostly like from the most basic low-hanging fruit of range of motion issues all the way up to integrated EMG dynamic loading work. And predictively, that will tell us with pretty good assurance whether you kind of have the propensity for injury on the bike or really any sport.
Okay. So for a guy like me who has done a million FMS tests, and every time I do them, I score like 20 or 21, which is perfect score. I've ran on $1 million treadmill up in Oregon, Bend, Oregon. This guy has this $1 million treadmill that has all these force sensors and EMG connections, and it looks at every vector of force that your foot is putting through the ground. So if you look at me and then you do all the movements, my ranges of motion are always great. So if you look at me from the outside, I test well, I move well, I have all these things, but I'm chronic. I'm always chronically injured. So why is it that some athletes are more prone to injury than others in your experience?
Sure. We see a wide range of reasons. Frankly, genetics is a huge part of it. So say for Matt and myself, we come from a team power sport background, transitioning over to endurance athletics can be very difficult for those types of athletes, which frankly, like in Boulder, is a lot of what we see. Folks that got into cycling and running later in life. Nutrition, previous injury, traumatic stuff, or overuse. There's so many reasons.
Okay. I was just going to say it's it doesn't sound like an engineer to go to a $1 million treadmill with like every force vector to try and fix himself, does it?
No. Yeah, right.
So some of us then are just genetically predisposed to injury more so than others.
I think yes and no. I think yes in the sense where like your tissue quality may just be a little bit different. Some people literally have torsion to their bones, which predisposes their joints to slightly more force during certain activities. But then you got to ask yourself if whoever's looking at you do these things is looking for the right area, or is there problem solving where it needs to be, right? So you can have incredible diagnostic equipment that you don't know how to interpret, or that you're just, or you may not have kind of like the biomechanical know-with-all or background that you can apply those principles to what you're doing. So the data is good as what you can do with it, or how you can interpret it.
And that's a lot like, I remember when Retool first came out, the bike fitting system where they put all the Vicon motion markers on your body. And everyone was saying, I'm going to go get a Retool fit. And what people fail to realize is that Retool was a tool. And if the guy using the tool didn't know jack about bike fit, you just got, a 3D model of yourself in a terrible position on the bike. So
absolutely. There's an art and a science to a fit and PT, and blending those two together is very important.
Exactly. Yeah. Okay, so when it comes to injury and those who are a little bit more susceptible to injury, when it comes to training for endurance sports, should those who are more susceptible to injury focus on lower intensity training and minimize the higher intensity work? Is there any correlation that you see with that?
Not with intensity. I think total volume is a big deal.
Okay.
So I think, if you're prone to injury and you're still not 100% confident in your ability to perform at your highest level, then just decrease total volume. But within that volume, I highly recommend people vary intensity, micro fluctuations in volume. And I don't think that necessarily is exactly the way to limit yourself. I'd say, just maybe limit your total percentages.
Okay. Very, very cool. And then aside from obviously keeping you training and limiting or recovering from injury, is there anything else that physical therapy can do to help us perform better on the bike?
Sure. I think we need to pay attention to mobility, right? As cyclists, I know when a cyclist is coming in the door because you look like one. Tight hips, tight thoracic spine, like we know immediately. And the ultimate performance enhancement is never getting hurt.
Right.
So if we can get on those foundational things immediately, and yes, maybe we're leaving a little something on the table as far as training load, but we're taking care of all that foundation work.
Right.
You stand a really great chance of being on the bike all season.
Exactly.
So, yeah. I mean, we deal with people who are willing to obviously pay a lot of money for marginal gains on a bike when a lot of issues can be solved, like we talked about before, with low-hanging fruit, with very foundational preventative work.
Right. So that being said, what are some of the best ways for cyclists to prevent injury before they even make it to somebody like yourself?
Sure. I would say hip flexor mobility for every cyclist is critical.
Okay.
Most of us are at a computer all day. Then I get out of work. I go hop on my bike for a couple hours. I've been hip flexion for 10 hours.
Right.
So moving our hips into extension is critical. I don't know that I've met a cyclist who couldn't improve that.
Okay.
And what do you, when you look at, certain things like, let's just look at hip flexor mobility. I've heard some people say, I'd rather you roll for 5 minutes than stretch for an hour. I've heard static stretching is good or static stretching is terrible and you need dynamic stretching. What are your thoughts on that?
The way that we practice, guys, is just more consistent with kind of what's been out in the literature. So when we are trying to change range of motion, meaning like if someone comes in and they have legitimate range of motion limitation in their hip extension, meaning they can't get their femur essentially past their torso with a flat pelvis, then that's when that static stretching is pretty warranted. And the time limit that we give people is 2 minutes. 2 minutes worth of static stretching has been shown to kind of have the most effect.
Yeah.
We're looking for low load and longer stretches as opposed to like high intensity, I'm going to tear my muscle off kind of stretch.
Yeah.
But we found that has the best result. If you do a little bit of that, so say you do 2 minutes twice a day and you do that a little bit, those gains really do add up.
Okay.
Sorry.
Yeah, no worries. Do you believe that having an injury prevention plan or working on this stuff ahead of time, if we do get injured, if that inevitable injury happens, does that help us get back on our feet faster?
Absolutely.
Okay.
So the injury prevention model, we could go talk for a few more hours about what can we actually prevent, but once you're injured and we see all these range of motion limitations, we're going to work on that anyways.
Right.
So we need to dial that in as soon as we can. And we see a lot of translation between, again, hip mobility, T-spine mobility, and limits up and down the chain.
Okay. I've heard over the years too, hear a lot of people talk about rehab. What do you do when you get injured? Rehab. And a buzzword I've heard recently is something called prehab. Do you guys use that word? Is it something that you use on a regular basis? Can you talk about that a little bit?
When it comes to after injury, before intervention, or just general?
No. So the word that I've heard prehab is it's people use it in a way where most people wait until something happens and then they go through this rehabilitation program. And so a lot of the stuff that I've seen lately is, instead of just jumping on a bike, or if you're a runner, just going for a run, there's that prehab that you do before each one of your events or activities or after to sort of prehabilitate yourself.
Wake up the body and the nervous
wake up
system.
the body and prevent injury.
Yeah. So, we just call that performance. Yeah, no, that's just training, guys. We traditionally take people through, we ask most of our athletes to do some type of dynamic warm-up. So we do like a dynamic movement series, and that's actually all on our YouTube if you guys want to check it out.
Sure.
And then we also have people do what's called a muscle primer. So the muscles that we're trying to kind of focus on for that athletic activity, we try and prime them up like you guys talked about, increase that kind of brain muscle connection, get your coordination going, and then integrate it into your activity. At post activity, that's where we tend to recommend people to do those static stretches. That's where you want to warm down, not only for the muscles, but for your nervous system as well, right? You kind of like bring down your sympathetic response to exercise, and you start that recovery process pretty darn quick, right? We're usually either in fight or flight or rest and digest. So we want to try and create that calming process as soon as we can.
Rest and digest.
I've never heard that latter. That's awesome. Yeah, rest and digest. Okay, so a couple more questions. I've talked to a couple people lately, some of our customers and stuff like that, and there's these kind of interesting things that I've heard from them. So one is movement is a big thing lately. I don't know if you guys are familiar with the name Ido Portal. Have you ever heard of him?
I believe so.
He's the guy that Conor McGregor worked with. He's like a movement expert, and he's big on going through, taking all of the joints, the thoracic spine, the shoulders, the hips, the feet, everything through these big ranges of motion so that you, one, are basically using your body through all those ranges of motions on a regular basis. Because like you said, a lot of us sit at a desk, we type all day, our thoracic spine gets tight, our hips get tight, and we don't move. So a lot of these movement experts are basically trying to, I hate to use this word primal, but they want to restore our primal movement patterns.
I have seen this, yes.
What are your thoughts on that concept when it comes to performance and then also injury and injury prevention?
Well, I'm not familiar with that exact tactic, but I will say that in general, motion is lotion. And yes, we want people moving a lot, right? Our bodies it's as if we're cavemen. We want to be moving all the time. But movement efficiency is really important to us as far as an injury prevention or rehabilitation model. So more so than how much are you moving, we're looking at the quality of all of these movements and do they actually translate to your sport?
Okay. So if you have an athlete come in who is, one, has a restricted range of motion, and two, moves wrong, what is it that you do to get them back? Do you first establish the proper range of motion and then retrain them how to move? How do you retrain a movement pattern?
So a lot of what's out now, just like we use this analogy a lot. So we train the brain more than the body, right? So we're training movement patterns like you guys talked about over and over and over again. We found through same thing, a bunch of learning research that for movement quality, visual feedback is pretty darn important. So if you can't see yourself do something, then most likely than not, you're going to default right back into your base movement pattern.
Okay.
So we establish one appropriate range of motions, and we assign specific things for people to execute on the daily to at least normalize that range of motion.
Break those old habits.
Yeah. Yeah, okay. Exactly. And then we try and integrate that into specific, like immediate feedback movement patterning. And you can do that through a ton of different ways.
Wow. Okay. Very cool. All right. Now you mentioned the brain and the nervous system in that, and that actually kind of leads into the next question that I had. I was talking with a guy the other day, and he was mentioning this theory or this concept that our brain, when we get an injury for the first time, if we get an injury, your nervous system sends a pain response to your brain as an indicator to slow down and kind of stop. What he said was that when people who have been previously injured or injured multiple times, the wiring from the nervous system to the brain can almost get screwed up a little bit. So you see it in cases where there is symptoms of pain, but there's no mechanical or structural damage. So these people think that they're injured, but it's really the body has become hypersensitive to any type of pain. And he was saying that you have to rewire your brain to learn about what actually is pain and what isn't pain again. Have you ever heard anything about that, and what do you think?
Sure, that's totally true. Pain is an output from the brain, not an input from the body. So sometimes it's difficult to understand that pain does not equal tissue damage. Now, you do need to respect that sensation. And if you're not working with a medical practitioner and you're having pain, I would recommend you do that so you can kind of dial in what you're feeling. But that said, the brain is a very powerful thing, and we don't understand all of these processes. But you can train yourself to almost tolerate some of these sensations during training, right?
Yep.
But mechanical pain, it's really difficult to skirt around those different sensations. So you need to be really cautious.
Okay.
You just said something very interesting. I had to write it down. You said that pain is an output from the brain, not an input from the tissue.
Correct.
How into that one?
Yeah. Can you talk a little? Because if somebody punches me in the arm, I feel like I got a Charlie horse, right? So I'm like, oh, that hurts. I can feel it in my arm. How does that coming from my brain? Doesn't the sensation from the arm go to the brain?
So some sensation is being felt, yes, but the signal of pain is coming from your brain.
Really?
That's a protective mechanism, right?
Yeah.
We could be burning ourselves, and if we can't feel that, you get into trouble. So it really is an output from the brain.
Wow. Fascinating.
Very interesting. All right. Basically, our last question is how has to do with wattage. And every episode that we do on this show, we try and associate what we call watt points to it. So if you are perfect or you take the advice from the podcast that you've just listened to, it's worth X amount of watts on your FTP. And I know this is obviously very subjective and there's got to be a range. So you have permission to use a range. And the context in which I'll ask it here is obviously if you're injured and you're not training, your FTP's nowhere. And if you're not injured and you're training, your FTP is going to be good. But let's look at this from more of a symmetrical, a person who moves extremely well versus a person who's moving poorly. How much of a difference in output can you see from an athlete who moves poorly, and then you get them to the point where they move really, really well?
Guys, I mean, it's funny you bring this up. We look at this quite often.
Okay, good. That's why I asked you guys.
Yeah. No, we've seen people who come in who, exactly to your point, don't move very well. We stick them on their bikes. We do a lot of retraining. Then we stick them on their bike again. And just changes of position and cueing within one visit, they can actually ramp up around 10 to 12 watts on average of a 2-hour ride. So that's pretty darn successful.
Wow, that's crazy.
In our line of work. Yeah. If you incorporate more of the musculature that you're using on a bike, if you actually coordinate it all, and like Dane said, we're looking at efficiency of movement, the subjective and the objective return just skyrockets. It's fantastic.
That's awesome. That's really, really cool. Well, guys, I can't thank you enough for coming on the show. This has been a really cool and interesting podcast. If people want to learn more about Revo PT and you guys, where can they go and what can they do?
Yeah, they can go on RevoPTBoulder.com. We have all kinds of examples of how we treat. We have lots of blog posts for quick fixes for folks to use at home. They can find us on YouTube, Facebook, and Instagram at Revo Physiotherapy.
Awesome. Okay, and by the sounds of it, I should probably stop by the next time I'm in the area and have you guys take a peek at me.
Swing in before you go skiing.
Yeah, that might be a plan. All right, guys, thanks again. And again, thank you so much. This has been awesome. Have a great day.
Thank you, guys. This is great.
Thank you for listening to this episode. Be sure to listen to episode 4, where we take a deeper look at the field of sports performance. Prior to the episode, John and I visited UNLV's Department of Kinesiology and Nutrition Sciences, where we conducted a list of sports performance tests, including a VO2 max test. In the next episode, we interview sports scientists Ted Gerard and John Mercer to help us understand how sports performance testing can help athletes become faster cyclists. If you enjoyed the show, please help us by sharing our podcast and by leaving a rating or review. If you want to learn more about our company, FLO Cycling, please visit us online at flocycling.com. That's F as in Frank, LOCYCLING.com. You can also find us under FLO Cycling on Facebook and Instagram. Until next time, ride safe.